بسم الله الرحمن الرحيم. أنا الدكتورة أميرة مصطفى Consultant Medical Retina and Imaging Eye Care Eye Center. هتكلم معاكم عن ال Clinical Evaluation of Diabetic Retinopathy. Diabetic retinopathy is a progressive microangiopathy of the retinal circulation resulting from chronic hyperglycemia with subsequent vascular hyperpermeability, macular edema, retinal ischemia, and neovascularization. Diabetic retinopathy is classified into non-proliferative and proliferative forms according to many classification systems. The Early House, Modified Early House, and the ETDRS classifications used the 7-field stereoscopic fundus photographs as an accurate and reproducible tool for documentation and degrading of diabetic retinopathy status, as well as for diagnosis of vision-threatening macular edema. Non-proliferative diabetic retinopathy could be mild, moderate, or severe. Proliferative diabetic retinopathy could be early or high risk. Clinically significant or vision-threatening macular edema according to the ETDRS is retinal thickening at or within 500 microns of the center of the macula, presence of hard exudates at or within 500 microns of the center of the macula associated with thickening of adjacent retina, or retinal thickening of 1 disc diameter area, any part of which is within 1 disc diameter of the center of the macula. This definition was of utmost importance in the era of laser treatment for macular edema. The Icd Severity Scale classifies diabetic retinopathy also into non-proliferative and proliferative forms. The non-proliferative form into no apparent disease, mild, moderate, and severe disease. The severe disease follows the 4-2-1 rule: 4 quadrants of more than 20 intraretinal hemorrhages each, 2 quadrants of definite venous bleedings, and 1 quadrant of edema. Systemically, the duration of diabetes is associated with frequency and severity of the disease. The longer the disease, the more frequent and the more severe diabetic retinopathy and diabetic macular edema. Hyperglycemia and hypertension are also associated with more frequent and more severe retinopathy. Blood pressure control is associated with decreased diabetic retinopathy progression. Presence of dyslipidemia is also associated with formation of more dense intraretinal exudates and the higher risk of severe visual loss, as well as higher risk of progression into proliferative form. Other factors such as pregnancy and the presence of diabetic nephropathy are associated with higher risk of progression of diabetic retinopathy. The ophthalmic evaluation starts with history taking, the diagnosis of diabetes, the systemic disease, history of previous treatments, and presence of other comorbidities. Comprehensive eye examination regarding visual acuity, anterior segment evaluation regarding presence of neovascularization at the iris and the angle, posterior segment evaluation through dilated pupils using slit lamp biomicroscopy, and degrading based on fundus photographs, fluorescein angiography, and OCT. Fundus photography is useful for detection of retinopathy signs, documentation of diabetic retinopathy status, grading, and monitoring of treatment effects. Here is some pictures of signs of diabetic retinopathy at its different stages: the microaneurysms, the retinal hemorrhages, the hard exudates, and the cotton wool spots. In more advanced cases, the presence of subretinal fibrosis, the scars of laser treatment. In cases with proliferative diabetic retinopathy, we can see the neovascularization at the optic disc and elsewhere in the fundus, presence of fibrovascular proliferation, presence of hemorrhages, either vitreous gel hemorrhages or subhyaloid hemorrhages. In more complicated cases, we can see areas of retinal detachment, formation of dense epiretinal membranes and their complications such as formation of secondary macular holes, and of course the extensive areas of retinal ischemia affecting posterior pole and the peripheral retina. On fluorescein angiography, diabetic macular edema can be classified into ischemic, focal, diffuse, and mixed. We can use it for evaluation of retinal ischemia and monitoring of treatment effects using either laser or intravitreal injections. Here is some pictures of different stages of diabetic retinopathy. In non-proliferative diabetic retinopathy, we can see the hyperfluorescent leaking microaneurysms, the localized areas of retinal tissue hypoperfusion, sometimes the dark retinal hemorrhages and hard exits, hypofluorescent retinal infarcts consistent with cotton wool spots, and diffuse parafoveal capillary leakage of late cystoid patterns of macular edema. In PDR, we can notice extensive areas of retinal ischemia affecting posterior pole and the peripheral retina, presence of neovascularization at the optic disc and in other peripheral retinal locations, sometimes with nearby retinal hemorrhages, extensive subhyaloid hemorrhages, the presence of laser scars of previous PRP, and however, still there is hemorrhage and persistence neovascularizations. And in the lower right photo, we can see fibrovascular tractions with retinal detachment and the leaking neovascularization, of course. In quiescent PDR, we can see the attenuated vessels, the scars of extensive laser treatment, and the hyperfluorescent glial tissue remnants of regressing new vessels. When it comes to macular edema, it could be ischemic, focal, or diffuse, or mixed between focal and diffuse, ischemic, focal, and diffuse. When it comes to OCT, OCT is a non-contact, non-invasive imaging modality. When compared to the gold standard fundus photographs, it is less time consuming for the patient and the operator, less likely to be affected by media opacities, more accurate and more reproducible, provides quantitative and qualitative estimation of macular edema and its change with treatment, more sensitive in detection of subtle macular thickening and subretinal fluid collections, and allows, of course, detailed examination of different retinal layers, including the ISOS junction and the vitromacular interface abnormalities. On OCT maps, diabetic macular edema is usually seen as an area of retinal thickening that is often associated with loss of foveal depression. Quantitative assessment of diabetic macular edema on OCT includes the measurements of central subfield thickness, macular volume, thickness of outer retinal layers, and subfoveal choroidal thickness, while qualitative assessment includes the pattern of edema, the presence of vitromacular interface abnormalities, presence of hyperreflective foci, and the integrity of both outer and the inner retinal layers. The significance of evaluation of such parameters is due to the fact that macular thickness is just one of several variables that can affect visual acuity, and the many studies that used OCT-derived thickness measurements have failed to find a consistent correlation between the automatically measured retinal thickness and the visual acuity outcome. In 1999, Otteni et al. Described three patterns of macular edema on OCT, which are correlated well with the well-known fluorescein leakage patterns of macular edema. These patterns include spongiform edema, cystic edema, and serous neurosensory detachment. In 2006, Kaiser et al. Described 5 OCT patterns of diabetic macular edema in relation to vitromacular interface abnormalities. Vitromacular interface abnormalities are seen in OCT scans of up to 60% of diabetic macular edema patients, They include presence of epiretinal membranes, vitreomacular adhesions, and vitreomacular tractions. Identification of such patterns is very important as it may affect the patient's response to treatment and for the selection of the appropriate treatment plan. These patterns are diffuse retinal thickening, cystoid macular edema, subretinal fluid without posterior hyaloid traction, posterior hyaloid traction without tractional retinal detachment, meaning the presence of dome-shaped serous neurosensory detachment of the macula associated with an adherent hyperreflective posterior hyaloid band at the retinal surface. And the last pattern, the posterior hyaloid traction with tractional retinal detachment, meaning the presence of peak-shaped serous neurosensory detachment of the macular area associated with focal traction by the adherent posterior hyaloid band. More recently, in the current era of the anti VEGF therapy, the DRCR network classified diabetic macular edema into non-tractional and tractional forms. The non-tractional form is then categorized into non-center involving and center involving diabetic macular edema. According to the DRCR, center involving diabetic macular edema is defined as diabetic macular edema involving foveal zone, which is the central 1 mm area on the ETDRS grid circle with central subfield thickness of at least 250 microns on the time domain OCT 3 machines, or at least 300 microns on the more recent machines such as the Spectralis machine. Here is some examples of OCT maps of diabetic macular edema. We will start with non-center involving diabetic macular edema. We can notice mild thickening of the macula affecting the 3 mm ETDRS grid circle and within normal retinal map appearance, preserved foveal contour, and within normal central subfield thickness. Another example of center involving diabetic macular edema of either cystic pattern or mixed cystic and subretinal fluid pattern. Another example of center involving diabetic macular edema of the right eye of one patient spreading over the nasal macula, and the non-center involving diabetic macular edema with hyperreflective subhyaloid hemorrhage in his left eye. Another example of patient with bilateral center involving diabetic macular edema, which is non-tractional in the right eye and tractional in the left eye. We can notice the marked distortion of the underlying ellipsoid zone and the external limiting membrane. Another example of a patient with tractional center involving diabetic macular edema and the marked improvement in macular edema and retinal contour after vitrectomy in the lower right picture. We can notice the release of traction and resolution of edema and the restoration of a near normal foveal contour. More details about the lines of treatment and progression and regression of disease status will be in details with my colleague Dr. Mostafa in the next presentation. Thank you and good luck.